our next speakers. As they approach the stage, we have Mike Shai, MD from the University of Iowa, David Herman, MD from the University of Rochester, also known as CMTA royalty. So we're really pleased they could join us. They're going to talk about clinical outcome measures and clinical trial readiness for CMT. They have a slide deck, so if you could bring that up, that would be wonderful. And
make one comment from the last session.
Yes.
I'm a little concerned when you said that the kids don't have to do EMGs, because I'm afraid that the adults are going to try to get in as kids now. So, so there is an age cutoff, so don't try to fool us.
Everyone's going to try and pass for under 18 so they don't have to have an EMG. I'm sure I can manage. David's going to start, so thank you, everyone. David Herman.
So thank you, everyone, for the opportunity to participate today in the session. I'll get started, hopefully, until the slides come up. But we're talking on a topic of clinical trial readiness. Basically, conducting clinical trials is a complex... so the slides are up. Yeah, so it's a complex undertaking, and we don't take that lightly. And so there's a lot of work that goes in ahead of time to be able to conduct clinical trials efficiently. So you've heard this term a lot, clinical trial readiness, but what does it really entail? Clinical trial readiness is the state of having validated clinical research tools to be able to conduct clinical trials. And we also have to know the so-called natural history of CMT. And we use this term all the time, but what is natural history? It's just the usual disease course across individuals with CMT. And we have to know and have information on those two elements in order to be able to conduct trials effectively. So why is it urgent for us to become trial ready now? Well, you've heard all the wonderful work that's going on in our animal counterparts, and we can effectively treat many forms of CMT in animal models. But we have to translate that to humans now, and across multiple subtypes of CMT, as I said, we have effective clinical trial models. We're beginning to see clinical trials in humans. We've just heard about the PXT3003 trial that's concluding. We have the ongoing trial in sword neuropathy. And so we want to now proceed to trials in other subtypes of CMT as treatments become available. So in order to be clinical trial ready, over the last sort of decade to 15 years, really under Dr. Shai's leadership, who's director of our Inherited Neuropathies Consortium, we've really considered what are the components that we need in order to be ready to conduct effective trials. And so one gap, I'll be talking today mostly about clinical trial readiness in adults, and then Dr. Shai will discuss it in children. But if you go back 10 to 15 years, we really had very few tools to sensitively assess the severity of CMT and the progression of CMT, so-called clinical outcome measures. And we also lacked what we call biomarkers to assess whether treatments were working in CMT. So in terms of clinical outcome assessments, and I'll show you some examples of these, the key that regulatory bodies such as the FDA want to know before they approve a treatment is they want to know, does a treatment improve how patients feel? Does it improve how they function? Or does it improve survival, which thankfully in most forms of CMT is not impacted, but not in all. But the other component are so-called biomarkers. And this term is used a lot, but what is a biomarker? It's simply a marker, a biological marker in blood, other body fluids, or tissue that is really important because it can indicate for us whether a treatment's working. And while we do have these clinical outcome assessments that are important because we want to know that if there is a treatment, that it's actually having a meaningful impact on individuals' lives, which biomarkers don't necessarily tell us. But the thing with a biomarker is it may begin to change in response to treatment before an individual may notice a change in their symptoms or a clinician may notice changes in one's clinical examination. And that's why biomarkers are important, because they can give an earlier or more rapid indicator of treatment response. And so programs that are developing treatments will know earlier on in the development stage whether the treatment's working. So we've done some work on this, and again, through the Inherited Neuropathies Consortium, which we'll learn about in a little bit from Dr. Shai, we've developed an instrument known as the Charcot-Marie-Tooth Health Index. And if many of you might have participated in some of the natural history studies, you may have completed this or completed it on multiple occasions. But it's an instrument for adults where it's a questionnaire where we can use these very specific questions to learn about how individuals feel their CMT is impacting their lives. And this has now been translated into multiple languages. It was used in the Acceleron trial that was conducted a few years ago. It's being used in the ongoing SWORD neuropathy trial. Additionally, in terms of assessing how individuals with CMT function, my colleague, Dr. Kate Eichinger, and others of us within the Inherited Neuropathies Consortium have developed something for adults known as the CMT-FOM, or CMT Functional Outcome Measure. This evaluates many aspects of function in the upper and lower limbs, how an individual walks, one's balance, and it's a quantitative measure that we've developed and hopefully will be used to assess function in future clinical trials. In terms of biomarkers, I'll talk about imaging biomarkers. You heard earlier from Dr. Sfarron about MRI of leg muscles, and I suspect many of you may have had some of these MRIs. But the key thing is the team at University College of London, Dr. Riley, in collaboration with Dr. Shai, discovered that one can look at the fat inside one's leg muscles. Now, this is not the same as fat that we all have on our body, but generally in your muscles, normally you have very little fat. Fat makes up a very small percentage of your muscle. And as in CMT, but in other neuromuscular conditions, as the condition progresses, the fat content increases, and that's not a good thing. And so what we can tell with in CMT type 1A, but other subtypes of CMT, is that over a 12-month period, if you follow an individual who has an MRI 12 months apart, you can see the percentage of fat in the muscle slowly increasing. And so we can see that before we can see a change in an individual's function or strength. And so one of the things that we're interested in with the MRI is, can we give a therapy that stops fat accumulating in the muscle? And can we get, and that could be an early indicator or biomarker of treatment response. So there's been a lot of ongoing work on MRI. But what about sensory function? We talk a lot about foot drop and muscle atrophy, and these are key elements in CMT. But sensation is also important. It's really important for one's balance. It's important for one's hand function to be able to do fine activities. And our tools hitherto to really measure sensation have been quite limited. You can test one's ability to feel sharp with a pin. You can test vibration sensation, and those uncomfortable nerve conduction studies, we use them in CMT, but they don't serve us well when we talk about sensory nerve conduction studies, because in many subtypes of CMT, by the time we evaluate individuals, we can't even get a response on the sensory response. So some years ago, we developed something called in vivo confocal microscopy of Meissner corpuscles, which are touch sensory receptors in the skin. Yes, sorry, I went through that pretty quickly. But basically, we have a microscope where we can look into your skin and see the nerve endings that allow you to feel touch. And some of you who have participated in some of the studies may have done that. And then we can see whether we can quantitate them to see whether you have enough of them, are individuals losing them, or hopefully whether a treatment will restore them. So we've done a lot of work in developing these clinical research tools that are part of clinical trial readiness. But we don't just need tools, we actually have to see how they function in patients. So just a couple of sort of comments, we developed a protocol for something known as ACT-CMT, Accelerate Clinical Trials in CMT. It was funded through the NINDS. I'm involved, Dr. Shai and others. And this is a study in CMT1A to evaluate some of these tools. It started just when COVID hit, sort of end of 2019, beginning of 2020. But notwithstanding that, across 5 sites, including sites in Italy and the UK, we enrolled 215 adults with CMT1A. And enrollment, everyone is very willing to participate. And so far, everyone who's participated in that has been followed up for at least 2 years, and some individuals have had their final study visit at 36 months, but we're actually working and hoping to extend that because we think we need to get longer-term follow-up in CMT1A. And so far, we've taken that CMT functional outcome measure and modified it to develop something called a RASH CMT functional outcome measure. And it's a 12-item scale, and it correlates well with, for example, our patient-reported instrument, the CMT Health Index. And we're just now beginning to look at some of the data to understand how the CMT functional outcome measure changes over time in patients who've completed this. We've also got information from those 215 adults with CMT1A on our CMT Health Index, getting the patient's perspective on how CMT is affecting their lives over time. And what you can see from this graph and the various subscales is over a 12-month period, in general, individuals are not reporting much change in the impact of their CMT. But when we look at within the data, we see most individuals don't say they're changing much. When we ask individuals, are you staying the same? Are you getting a little worse? Are you getting a little better? Are you getting a lot worse? A lot better. Most individuals say over a year's period of time, I'm staying about the same. But there are individuals who say they're a little bit worse and very few who say they're a little bit better. And by looking at the individuals who say they're a little bit worse, we've now been able to determine what change in the CMT Health Index equates with individuals noticing a change in their condition. Turns out on a 0 to 100 scale, it's 3.2 points. So this information will be useful. It's called the minimal clinically important change for us to determine in a treatment if there is a change, is that something that of a magnitude that individuals would think is meaningful, which is important in the drug approval process. Briefly, wearable sensors. So I'm wearing my Apple Watch today, and many people have their Fitbits. And so, we're in a digital age, and we can capture a lot of information by putting painless sensors on individuals that you can wear at home, that you can wear while you're doing balance tasks or walking tasks in the clinic. And Josh Burns from University of Sydney and Dr. Kate Eichinger, my colleague, and many of us in the Inherited Neuropathies Consortium under Dr. Shai's leadership have been doing a study in CMT1A where we've been tracking individuals using wearable sensors. We definitely see significant differences between CMT1A and individuals who don't have CMT in many of these quantitative parameters of how much you're swaying, what's your stride length, what's your stride velocity. And we're now beginning to look at the longitudinal data to see which of these individual parameters or elements of how we walk or how we balance may be the most sensitive to assess in a clinical trial. Can we put a sensor on our body, give a treatment, follow someone for a year, and actually learn very quickly whether we're improving balance or gait? The CMT Association funded a study for led by Dr. Eichinger to see if we can come up with a specific algorithm or a specific protocol for CMT, because these wearable sensors are being used across conditions. And so we've done some work to see if we can modify protocols so that it's particularly suited to CMT. Switching now to a different type of CMT and some of our work in CMT4C, which is just beginning. So we heard earlier about CMT4C, but CMT4C is one of the most common recessive forms of CMT, although still exceedingly rare. Effective individuals carry variants in each of their copies of this SH3-TC2 gene because it's recessive. You need a variant from your mother and one from your father in order to be affected. And symptoms usually begin in childhood, but some individuals first notice them in adulthood. And one of the key features is early scoliosis and severe scoliosis, often in childhood, and it may be the first symptoms individuals have. And why am I talking about CMT4C today? You all heard, if you were in the CMT1A or the CMT1 session, you heard Dr. Cleopas speaking to us by recording from Cyprus. And not only is he leading the way in CMT1A and CMT1X, but also in CMT4C because he's developed an effective gene therapy for it. And so where we all come in is we're starting to talk about clinical trial readiness so that hopefully we can engage industry partners in order to develop an approved therapy. And my colleague at University of Rochester, Tyler Rabine, on behalf of the Inherited Neuropathies Consortium, looked at our data of 56 individuals with CMT4C. And it's a busy slide, but the graphs to the right show that it wasn't a detailed natural history study, but using something called our CMT exam score, we found that really CMT4C, although it can be very severe, it has variable severity, is also like other types of CMT changing very slowly, even over 5 or 6 years. So we're just about to plan as to how do we engage on the same kind of clinical trial readiness studies we're doing in ACT-CMT for CMT1A. We're hoping to do for CMT4C because there is this possibility of preparing for gene therapy in other trials. So we haven't yet tested any of these instruments I've just talked about in CMT4C. And so we're in the planning stages, but we have to identify partners and a way and funding to do this, to do a detailed natural history study in CMT4C. And in addition, we want to develop a global worldwide registry for CMT4C, because for very rare forms of CMT, we have to identify as many individuals who can participate in trials. So I'm going to stop there and turn things over to Dr. Shai.
So thanks, everybody. And my understanding is that I'm keeping people from drinks and the end of a long day, so I'll try to be quick. So I'm going to start by just introducing the Inherited Neuropathy Consortium, but it's, in some ways, it's a funny introduction because I'm introducing you to you. Because what this is our network of sites around the world where we partner with people who have CMT with you. And it's only because of this partnership that we have the data that I'm going to talk about. And when you come into our INC clinics, we examine you, we ask you if you can feel things, we check muscles, we poke you with a pin, hit you with a hammer, all these other nice things. But this is actually, what I'm going to show you is what happens with a lot of this data. So the Inherited Neuropathy Consortium has 20 sites. It's been supported by the CMTA since 2009 when it started. And we follow now over 8,000 patients with inherited neuropathy. And we follow them in a standardized way with outcome measures that people have been cross-trained on. And I'm going to move away from CMT 1A, and I'm going to move into 3 of the 4 genes that are part of what's called the 4-gene study supported by the CMTA. And I'm going to just show you what we've been able to accomplish so far, again, because of your participation. So these 3 genes I'm going to talk about are the 2nd, 3rd, and 4th most common forms of inherited neuropathy. So the first one is going to be CMT1B, and this is caused by mutations in the myelin protein 0. And using this instrument called the CMT exam score, starting in 2009, we've been able to follow hundreds of patients over the years. And a couple of years ago, we were able to publish our results with these, and this is what we're able to do with this kind of data. So if you look at this graph on the bottom, you see it's, I don't know if this works, let's see. Yeah, you can see it slowly moves uphill here, which is showing progression over the years with this population from when we first began seeing patients. And it's a little hard for me to read the boxes on the bottom from here, but what they show is at the end of 2 years, you can now detect progression in this population of patients that's clinically significant. We use what's called a p-value, and that p should be less than 0.05 if a change is significant. And we have something else called a standard response mean, which gives us an idea of how many people we would need to have in a clinical trial to show if the treatment was modified. And we can begin to get numbers that are realistic after 2 to 3 years. And again, we know this data because of your participation in coming to the INC clinics. Now, this is also showing one other thing that comes out of this study, that CMT1B is caused by mutations in a gene called myelin protein 0. It's a myelin gene, so most patients, or many patients, have slow conduction velocities, and these present early in childhood, and they can be very severe even at a young age. But then there's a whole other group that, for reasons that are unclear, get a presentation that looks more like CMT type 2. And sometimes this gets called CMT2I or CMT2J instead of CMT1B. But what we found in these adult natural history studies is here we can detect progression much more rapidly in this group in adults than we can with the demyelinating group. And that suggests, one, that in adults, maybe the axonal group would be a more ideal target population, but it also suggests that we're missing with these the changes that occur in the demyelinating form, and I'm going to come back to that. Now, just in the last year, we've published from the INC database on the next 2 forms I want to talk about. So the first one is CMTX, the X-linked form of CMT, where mutations are in a gene called gap junction beta 1. And again, we have data on hundreds of patients because we followed these patients for many years. And again, you can look at these graphs starting low and moving up. So at the end of 2 to 3 years, we can detect progression in the group overall. That's significant at 2 years and particularly at 3 years. But as we separate out these patients and we sort of separate out with those patients who we saw that were more severely affected compared to the milder ones, you can see on the milder ones, which is this blue here, you can see the progression is much more rapid than it is in the patients who started their evaluation at a more severe state when they first came in. And here we find for the mild group that standard response mean is up to 0.9, which is almost as powerful as the MRI changes, meaning that you could have a clinical trial in those patients, maybe with less than 100 people in each arm. So again, because of the power from this natural history data, we're able to really get a sense of how CMTX is progressing, and again, to see who might be ideal targets for treatment. And this just shows the same thing in a table form. And these are the years here and the standard response mean, and you can see it gets up to 0.9 after 3 years. Well, this is my water. I don't want your germs. If I start talking with a South African accent. Okay. So, and the last big group is the CMT2A population, which just came out in 2023 also. And as with the other subtypes I'm talking about, from this data, we've been able to see that we can detect significant changes with a good standard response mean within a 2-year period. And the reason that there's 3 different lines here is that we're able to look at each of the individual mutations within this group where we have reasonable numbers of patients and we can track the rate of progression. So again, using our traditional outcome measure, we're able to sort out progression in these patients. But a big change has occurred based on work led by David in the ACT-CMT study, because that tells us that it's nice to be able to detect progression with these measures based just on a neurology exam, but it doesn't get at function, and it doesn't get at a patient's own feelings of how a disease is changing. And so what we're working on now in the 4-gene study is we're using some of these other clinical outcome measures that David has talked about, and such as the functional outcome measure, the CMT health index, and I'll talk briefly about biomarkers in a minute. But we're looking at all of these as part of the 4-gene study because we want to see how these changes occur with these other outcome instruments. And that's what's called, again, the 4-gene study, and that's a study that involves basically the same sites that are in the ACT-CMT study, but in this we're looking at CMT1B, CMT-X, and CMT2A. There's 5 sites. We're doing all the functional outcome measures that David talked about. We're doing biomarkers, which I'll talk about briefly in a minute, and we're also looking at imaging because we want to be able to have this composite battery of outcome measures to detect clinically significant change in these groups as well. Now, this is a position paper that David, myself, and several of us wrote that was published this year, because I think it's really important as we try to be clinically ready for clinical trials, because these clinical outcomes are important, but we really need surrogate biomarkers to be able to go with the clinical outcome measures to show that we're changing the biology of the disease as well as clinical effects. And these are David talked a little bit about it, but just to briefly go over why these biomarkers are important. So first of all, if we're fixing the disease, we ought to be able to see changes in consequences of the disease in blood. Sometimes, I'm not going to talk about skin biopsies, but sometimes we see changes there. We ought to be able to show that treatments are hitting the target. Like for CMT1A, it's caused by an extra copy of PMP22, so PMP22 levels are increased. We want to be able to show that we can decrease those levels with the treatment. And then with imaging, which has been by far the most sensitive measure of change we've seen so far, it gives us a way to detect progression more quickly than we might see with clinical progression. And if we can predict what's going to happen clinically based on those MRI changes, that really becomes much more powerful for trying to run clinical trials. So again, that's sort of the reason we're looking at these biomarkers. And I don't have a lot of time, so I'm just going to just mention briefly that these are, some of them we look at in blood, and when nerve axons degenerate, they release a protein called neurofilament, and we can measure that. And in some human diseases, neurofilament has lowered and become normal with successful treatment. That's also true in animal models of CMT. And this is looking at other biomarkers that are called microRNAs, which sounds like doctor talk, I realize, but these are little pieces of mRNA which can encode proteins, or they can bind to DNA, and you can measure these in the blood also, and these are elevated in different subtypes of CMT, including the ones that we're talking about. Okay, so I feel like I'm sort of roaring through things, and I'm going to totally switch gears here, because I want to come back to what I mentioned with the CMT1B project, that many, though not all, but many types of CMT present with children. And ideally, people always ask us if treatments are going to slow progression or going to reverse the disease. And after CMT has been going on for a while, you get degeneration of axons, which you would have to fix even if you stopped the cause of the disease. So ultimately, we all believe it's better to treat early. And also, ultimately, once treatments are safe, we want to be able to treat children before they develop problems. And I think that point came across in some of the previous discussions. And we have a lot of natural history data on adults, biomarker data on adults, but we don't have enough on kids. I think David showed you the CMT functional outcome measure. That was based on what's called the CMT pediatric scale, which has been around since 2012. And again, it's a functional scale. It has measures of dexterity, balance, 6-minute walks. The kids have to do things, and it's been really an excellent way to look at the functional part of kids. This works for children who are between 4 and 20. And because of work by Josh Burns and his colleagues, looking at 1,000 patients, 1,000 people without CMT in Australia, we have normative data for all these age groups, so we can normalize what a 15-year-old should be able to do compared to a 4-year-old. Then, more recently, we wanted to be able to get as early as possible, and so we've developed what's called the CMT infant scale, and this is for infants and toddlers, so basically from a month of age up to the age of 4, ways to see how kids are doing compared to what they would be predicted to do. And whoops, what did I do? That's supposed to be a film clip, so maybe it's because I hit the wrong button. That would never happen. Yeah, so this is what the kids are doing for gross motor activity. And then fine motor activity. And so, again, we have the ability to look at kids of really all ages. And then I'm going to try to say this clearly because I think it's an important point. We don't want to diagnose children who aren't really having any symptoms when we don't even have a treatment yet for them. So rather than give a diagnosis when we do these early onset kids, if a child is at risk, we just keep them in an at-risk group so we can know that they possibly could develop clinical CMT, but we can get access to very early data so we can sort of see where the presentation and progression starts. So I hope that makes sense. Now, the next thing is that David talked about the CMT Health Index, and so we want to have something equivalent for a patient-reported instrument for kids. So this is work led by Sindhu Ramchandran, and so we've developed what's called a pediatric CMT quality of life, and this works for children from 8 years of age up to 20 years of age, and again, this is done through a QR code and a survey which comes up on an iPhone or an Android. And this gives us a patient-reported outcome measure for kids. And then we have versions of that which are called the parent proxy versions, where the parents fill this out also. And because the parents are filling this out, we're able to extend this all the way down into to after birth. So there's a parent proxy version for kids 0 to 7 and 8 to 20. And interestingly, there's pretty good agreement with the parents and the kids on this. And because of work by our colleagues like Josh and Kayla Cornett in Australia, and then also people like Kate Eichinger, who David already mentioned, we have online scoring for all of these, which are normalized to a patient's age. So why am I droning on about these? Because it's really important for us as we start building up these natural history studies to get clinical trial ready with kids with CMT. We don't torture the kids. I think most of the time they have fun doing these outcome instruments, as was mentioned. And so we really encourage you to help us get this ready, because we want to be able to treat people of all ages with Charcot-Marie-Tooth disease. And so I'll stop keeping you from your drinks. Okay, thanks. Okay.